Good evening, everyone. So, this is the case of a young lady, a sweet young lady. So, please present the case presentation. Thank you, sir. So, this is the case of 14-year-old female who had a lower respiratory tract infection and was diagnosed to have an elevated GRBS and a high HbA1c with a normal C peptide in the year of 2023, for which she was given insulin for 6 months, after which it was stopped, and on diet her fasting blood sugars were maintained. Okay, so what are your differential diagnosis at this point of time? Sir, because she's a young female who had high blood sugars and HbA1c, my first diagnosis would be type 1 diabetes. The other diagnosis I would consider is be uh, latent adult diabetes LADA and MODI are the other differential diagnoses I will consider for this patient. So, why do you consider type 1 diabetes as your first diagnosis in this case? What are the points that favor type 1 diabetes? Sir, she has been diagnosed as a case of diabetes at a very young age. So, what additional history would you like to have in these patients? I would like to know the family history of these patients. Family history of these patients. I would like to know for any other history like any pancreatitis or chronic pancreatitis or malabsorption this patient had. That is the extra additional history I would like to get in this patient. So, do you think that type 1 diabetes mellitus is a result of insulin deficiency or insulin resistance? Sir, it is actually actually due to insulin deficiency. So, what do you think the C peptides will be like in type 1 diabetes mellitus? C peptides will be low, sir. So, what is it in this case? C peptides are within normal limits. So, would you like to revise your diagnosis? Sir, then other possibilities like LADA and MODI will be the first diagnosis. Is the why do you in what is the treatment that you would give in LADA and MODI? Do you think that the insulin can be stopped? If so, it can be stopped. In which condition do you think that the patient will be just maintained on diet? I'm not very sure, sir. I think MODI. Okay, proceed. So this is the family history of this patient. So just elaborate. So thank you, sir. So this patient is now admitted with a deliberate self-harm, and is a known case of diabetes since 1 year. And both her parents are diabetic, and three of her grandparents are diabetes. So she is having a clear history of type uh, diabetes mellitus, probably type 1 diabetes mellitus, because it is present along multiple generations. So, other than type 1 diabetes mellitus, what other diabetes mellitus can have family history? Sir, LADA and MODI, both of them uh, can have a positive family history. Do you think LADA has a positive family history? Not very certain, sir. Okay, proceed. So, general examination of this patient is normal. Systemic examination is normal. So, these are the investigations which we had done from our side. So, just go through it. For this patient, C peptide is normal and counts are normal. CRP is normal. She has an ABG where the pH is within normal limits. She just give the positive findings. Okay, sir. So she's having a hyperglycemia with a glucose of 623. Other than that, everything looks fine for her. Okay. So the ECG is within normal limits. So what is your provisional diagnosis at this point of time? Sir, because of the young age of onset, I would like to, and because the C peptide is normal, I would like to revise my diagnosis as a case of MODI, because in type 1 diabetes mellitus C peptide is normal because of clear insulin deficiency, and because she's having family history within three generations, and is a young patient. I would like to revise my diagnosis Modi. Okay, so uh, so because she came with deliberate self-harm, that is one thing. Then she had mild to moderate depression and type 1 diabetes, case of Modi, as you said. Yes, you're right, case of Modi. So which investigation would you like to do next? So for her, the one investigation I would like to do is the anti-GAD antibody, which is within normal limits. Any other investigation which you would like to do? Sir, mm, I would like to do the other genetic testing for Modi. So is it widely available? Um, no, sir. So in clinical practice, the other investigation that we usually do in young drivers is a USG abdomen, where we look for pancreatic deficits, or developmental problems, or like renal anomalies, renal cysts, which are associated with Modi. So for this patient, actually you can see there's a renal cyst, but other than that, there's no pancreatic abnormality seen. So as you said, Modi is the diagnosis. So what are the points favoring Modi? Sir, young onset of the disease, positive family history, and a normal C-peptide. Anything else? What about the antibody status? Yes, sir. And Modi antibodies are negative. Yes. So that is another point. Anything else favoring Modi? What was the treatment given for this patient? So the patient received insulin for 6 months, after which was discontinued. So do you think insulin can be discontinued in type 1 diabetes mellitus? No, sir. What about Modi? Not sure, sir. Yes, in Modi also you can discontinue insulin and patient may be on diet. So for this patient, the positive findings were that she was a young patient, normal C-peptide, insulin was stopped, and still on diet. The patient was maintained between sugars of 120 and 30, and positive family history with normal antibodies. So this was the thing that we found. So what is the diagnostic criteria of Modi? Sir, early onset diabetes, non-insulin dependent diabetes. Yes, that is the point. That should be like the patient can be off insulin, and even when she's off insulin, her C-peptide levels will be normal, suggesting that the insulin secretion is within normal limits, and that positive family history. So, as you said, genetic defects are the cause. So, if it is not due to insulin deficiency, what is the cause? Hmm. So usually the cause is that something altering the beta cell function. So what is the beta cell function? The beta cell function is the production of insulin. So what happens in Modi? The beta cells are functioning normally at a basal level or slightly reduced, so insulin secretion will be there, but the baseline insulin secretion may be low. Maybe low, or when the patient has more glucose in her body, in her or his body, the beta cell will not appropriately hyperfunction. So it is actually more to do with, so because the basal insulin is normal, the C-peptide may remain normal, and if the patient can be put on diet, or sometimes sulfonylurea, something that increases the beta cell function, the patient may do well. Okay, so that is the thing. So what are the types of diabetes mellitus you know? Type 1 and type 2, sir. Anything else? Modi, sir. So where does LADA come? So we have type 1. So type 1 itself, there is it has got a type 1A, which has the antibody, type B, which has no antibody, and there's the latent onset diabetes mellitus in adults, or LADA, and there's type 2. So where does Modi come? So 90% of the patients are of type 2, 5 to 10% are type 1, and the rest are atypical. So the atypical patients, they do not have a specific antibody, they do not have specific pathophysiological factors like obesity or metabolic syndrome. So they do not have specific antibody, and they do not have specific pathophysiological factors, and Modi is one such criteria. So usually some genetic alteration may be there associated with Modi. So what are the differences in type 1 diabetes mellitus? How does a history help you? So history and the profiling of the patient help you. So suppose a patient comes with type 1, type 2 Modi, what is the difference in the age? Sir, the type 2 will be of an elderly age. whereas type 1 and Modi may have a lower age. Correct, absolutely correct. So in type 2, it is an age more than 25. What are the build of the patient? Sir, a type 1 is associated because it's insulin deficiency, the patient will be lean. Hmm? Lean. What about type 2? Type 2, the patient will be a bit more obese. So, okay, yeah, you're absolutely right. So, what are the other clinical findings that you find on general examination in type 2? So, acanthosis nigricans, skin tags, obesity. Yes, the patient will have be obese. What about Modi? Sir, lean patient, sir. Actually, in Modi, because I just told you there are no actually clear pathophysiological factors, obesity may not be there. It will usually be like the indigenous population. So in type 1 it will be a thin patient, type 2 will be obese patient, type 3 or like sorry Modi, it will be similar to indigenous population. What about the antibody status? So type 1 antibody will be positive, type 2 there is no antibody, type 3 will be antibody will be negative. Actually you are correct, but in type 1, as I just said, type 1A will have antibody, type 1B doesn't have any antibody. Which of the diabetes will have insulin deficiency? Type 1. Yes, correct. Type 1 will have insulin. What about the insulin sensitivity? That is, what happens when the insulin is produced? The insulin goes and acts on the various receptors. And what about the sensitivity? So in type 1 insulin deficiency, so insulin sensitivity will be there. Type 2 insulin sensitivity will not be there. Modi also insulin sensitivity will not be there. So you think Modi doesn't, the insulin sensitivity is low? Hmm? Actually, in Modi also the insulin sensitivity is normal. Normal. It like that's why the patient responds to insulin. You give the insulin, the sugar will get controlled. But in case of type 2 diabetes mellitus, because of insulin resistance, you may have to add metformin and drugs that increase the insulin sensitivity. So Modi is actually a problem with the genetic level, maybe because of the problem with the beta cell function, where the insulin may be adequately produced and it can be maintained by altering the beta cell function or a diet. But the insulin sensitivity is normal. What about the family history? Sir, type 1 and Modi will have a positive family history, type 2 may not. So actually it's percentage. So in type 1 it's 5 percentage, because actually the type 2 diabetes mellitus is the one which has the maximum family history, hmm, than type 1, which may have only a 5% of history, and Modi runs as multi-generational. What about the DKA prevalence? Sir, type 2 has a higher DKA prevalence. You're sure about that type 2 has a positive DKA prevalence? Would you like to revise your answer? Sir, type 1, yes. Type 1 has a high degree of DKA. What about type 2? What does type 2 proceed with? What is hyperosmolar hyperglycemia? Yes, sir. Yes, sir. Hyperosmolar hypoglycemia occurs mainly in type 2 diabetes mellitus. What about Modi? Modi DK prevalence is low, sir. Okay. So when do you suspect a patient to have Modi? Sir, a young patient with diabetes, as you said, sir, insulin secreted C peptide will be normal, family history will be there, antibodies will be negative. Correct. So it will usually be a young non-obese likely to be treated with insulin. Actually, only sulfonylurea is required. Hmm? Screen to identify the family member. So, what is important to identify Modi? So, the treatment. Yes, some of these patients, because of the young age, you may diagnose the patient to be having type 1 diabetes mellitus, where the patient may only require sulfonylurea, and also it helps you screen the family members. Hmm? And because these patients are non-obese, usually that will happen. They'll be like diagnosed as cases of type 1 diabetes mellitus. What are the indications of antibody testing in diabetes? Sir, young diabetes mellitus, sir. Hmm. What else? So it is young diabetes mellitus, low BMI, that means a lean patient. Family history of young diabetes mellitus. Any patient who has having a history of autoimmune disease, many of the autoimmune diseases are associated with diabetes mellitus. So person of family history of autoimmune disease, even maybe a thyroid disease, you may have to check. Hmm? So then adults with unintentional weight loss at the time of diagnosis and subtherapeutic response to sulfonylurea or metformin. Hmm? Okay, so suppose the early diabetes, the sulfonylurea and metformin may not be properly working. So in Modi, usually response to sulfonylurea. Type 2 diabetes metformin usually works. So when you have a subtherapeutic response, then also you have to consider the patient for antibody testing. What is the criteria for Modi? So it is like the patient should have it for more than 3 generations, negative antibody, and type 1 diabetes mellitus criteria should be ruled out. So patient should have normal C-peptide and when the glucose is more than 72. So three things: the family history, negative antibody, and a normal C-peptide when the sugars are less than sugar when the sugar is when the glucose is more than 72. What are the antibodies tested? Sir, GAD65, sir. Then zinc transporter 8 also is there, sir. Okay. So GAD65 antibody is one thing tested, and islet cell antibody are the two antibodies which are major antibodies that are tested for all patients. So then there's a panel of in the other antibodies like the insulin antibody, tyrosine phosphatase antibody, tyrosine phosphatase, insulin associated protein 2 and 1A 2 beta, zinc transport rate, and at least two antibodies need to be tested in these patients. So, what is the genetic defect in Modi? So you can see this table. Yes, sir. So this table, the old criteria was types 1 to 6, where type 3 was the most common. Sorry, type 1 was the most common type. But now they have revised that. Now it's like now the new system it bases it on the mainly on the genetic defect rather than anything else. So, for example, when you see in these patients, you can actually see what you find here is that so the first, the type 3, the old type 3, the new one is hepatocyte nuclear factor 4 alpha, which is there on chromosome 20. Its frequency is less than 10. So the first one, three thing to remember is that the 1, 2, 3 are the most common, of which is 1 is the most commonest, 1 is the old denominator. So the commonest one is hepatocyte nuclear factor 1 alpha on chromosome 1. That is present in more than 50%, 52 to 65. So what happens here is that the abnormal insulin secretion. So it is not low insulin secretion, it is abnormal insulin secretion. Okay, so that is what is happening here. So the insulin, when what happens is that there will be low renal threshold and renal glycosuria. So what differentiates this from type 1 diabetes mellitus is that in type 1 diabetes mellitus, even though the abnormal insulin secretion is there, you cannot give a sulfonylurea and stimulate it. You have to give insulin. But here, because the abnormal insulin secretion, you can give a sulfonylurea that will actually take care of this. And this is the most common variety, and the patient's urine will also contain glucose because the insulin secretion is low. The body has remodified itself so that even in the normal renal threshold is not reached. Renal like there will be renal glycosid. What is the normal renal threshold? Sir, 180, sir. If the blood glucose goes more than 180, that may be glucose in the urine. Yes. So that may come lower. So you get more renal glycosuria. And these patients develop microvascular complications like peripheral neuropathy, retinopathy, and nephropathy. Yes, correct. So the old type 3 is now the hepatocyte nuclear 1 factor 1 alpha chromosome 1 more than 50% abnormal insulin secretion. So you just give us sulfonylurea, increase the insulin secretion. Body has modified itself in such a way to reduce it. So the threshold of the kidney is reduced. So renal glycosuria occurs early. If not treated, you get microvascular complications. Now the second one is glucokinase on chromosome 7. So it is between 50 and 35%. So here it is a glucose sensor. It's not the reduced secretion. That is, there is a glucose sensor. What does a glucose sensor do? When the glucose increases, it has to give a stimulus to the beta cell. So when the sensor is reduced, an increased glucose, very high glucose may be required for increasing the insulin secretion. but the baseline insulin secretion is normal. Okay, it is a problem with the sensor. When there's more glucose, more insulin may not produce, but baseline insulin secretion will be normal. Because of this reason itself, the diabetes is mild and non-progressive. Because the baseline insulin secretion is normal, there are no microscopic complications. And here the only thing you have to do is a diet. Because there is adequate insulin secretion, you just have to maintain the body glucose with diet. So this is glucokinase on chromosome 7. Now the third one, which is hepatocyte nuclear factor 4 alpha on chromosome 20. Okay, the less than 10%. Here the insulin secretory response is reduced. Okay, so here also the treatment is sulfonylurea because the secondary response is reduced. So what I'm highlighting is that you have got type 1, type 2, type 3. Type 1 is the hepatocyte nuclear factor 1 alpha, which is the most commonest. Here is an abnormal insulin secretion. Increase that with sulfonylurea. There will be renal glycosuria. Then type 2, here is what happens, the problem with the glucose sensor. So the only thing is that you need to just maintain the glucose within quite a normal limit with diet, because the basal secretion is normal. Then you have type 3, which is hepatocyte nuclear factor 4 alpha on chromosome 20, that is less than 10%. Here also the insulin secretory response is reduced, but different from the type 1 is that there is no renal glycosuria, but this also has microscopic complications, and you have to treat with sulfonylurea. Now going to 4, 5, 6, the one thing about 4, 5, 6 is that most of them have some pancreatic problem. So in type 4 it's pancreatic agenesis, type 5 is pancreatic atrophy, and type 6 also some degree of pancreatic development. They are very less, and because of the pancreatic involvement they usually require insulin, and they all have microvascular complications. So summarize them all together. Which is the most common one? That is the old type 1. Now hepatocyte nuclear factor 1 alpha on chromosome 1. It is more than 50% prevalent and has abnormal insulin secretion and is sulfonylurea. The second most common one is the glucokinase on chromosome 7, which is 15 to 30 percentage and has a defective sensor. And because sensor is broken, the increased glucose in the body may not result in increased insulin secretion, but because the baseline insulin is there, it is a mild and non-progressive disease which only requires diet. So most probably this patient was in type 2 because she was maintained with diet. Type 3 is the hepatocyte nuclear factor 4 alpha on chromosome 20. This is less than 10%. Here also the insulin secretory response is reduced. Treatment is sulfonylurea, but it has no renal glycosuria when compared to type 1. 4, 5, 6 are relatively rare, and they're all associated with pancreatic involvement, so they all require insulin and they all have microvascular complications. Thank you.